Hello. Thank you very much for giving me the opportunity to speak to you today about the management of pregnancy hypertension, the CHIPS and the CHAP trials. I'd like to start by disclosing that I was the principal investigator of the CHIPS trial, the control of hypertension in pregnancy study that I will speak about today, and as such, I am a recovered less tight controller of pregnancy hypertension. Now let's start with a bit of history. Randomized controlled trials showed long ago that antihypertensive therapy in pregnancy reduces the incidence of severe hypertension, classically defined as a systolic of 160 and or a diastolic of 110 millimeters of mercury or more. This meta-regression analysis of randomized controlled trials compared with either no treatment or another antihypertensive showed that a greater antihypertensive-induced fall in mean arterial pressure, as indicated on the x-axis, was associated with a higher incidence of small for gestational age infants, represented on the log scale on the y-axis. And a reluctance to treat non-severe hypertension in pregnancy has been based on uncertainty about the importance of severe hypertension as an outcome worthy of avoidance and concern that treatment may impair fetal growth. Now, the CHIPS trial, the control of hypertension in pregnancy study, recruited from 2009 to 2012 and was published in 2015. And CHIPS was specifically designed to answer the question about the benefits and or risks of antihypertensive therapy in pregnancy. 987 women with non-severe chronic or gestational hypertension were recruited at 14 to 33 plus weeks gestation, because we figured that whatever you did with antihypertensives in pregnancy, presumably you would need to do it for a period of time if you were to have an impact on the fetal well-being. 75% of women had chronic hypertension and 25% had gestational. Women were randomized to less tight control with a target diastolic of 100, and this was designed to minimize use of antihypertensive therapy. The mean blood pressure achieved was 139/90, or they were randomized to tight control with a target diastolic of 85. And so the mean blood pressure achieved was 133/85. So as such, blood pressure was 5.8/4.6 millimeters lower in tight control. Women were recruited at a mean of 24 weeks and treated for 12 weeks of pregnancy, and about 25% were taking aspirin at randomization. Now, this is a very simple algorithm that was used to achieve tight control. So the target diastolic was 85, as you see at the top, and if diastolic were 81 to 85, no change in antihypertensives were made. If diastolic were greater than 85, then the dose of existing antihypertensives were increased or a new medication was started. And if diastolic were less than or equal to 80, then the dose of existing medication were decreased, or if the dose were already very tiny, then it was stopped. But of course, at any point, if systolic were greater than or equal to 160, then antihypertensive therapy was started or increased as well. The primary outcome was pregnancy loss or high-level neonatal care for greater than 48 hours, so a measure of death or illness. And this did not differ between the groups, 31.4% in less tight control versus 30.7% in tight control. The secondary outcome of serious maternal complications, which was one or more of things like dialysis or blood transfusion or eclampsia, did not differ between the groups either, but it was 18 or 3.7% in less tight control versus 10 or 2% in tight control. The number of events were 18 versus 10 women, of which the vast majority were blood transfusion, all of which was postpartum. And there were no important subgroups for which treatment effect was different, including the type of hypertension. But there were important secondary outcomes that differed between the groups and are of note. Severe maternal hypertension was significantly less common in tight control, so you see 27.5% here. Platelet count under 100 was also significantly less common in tight control, as were elevated liver enzymes with symptoms. Birth weight less than the 10th centile and preterm birth did not differ between the groups, but I will return to this point because some people have felt that, well, in less tight control, 16.1% may have been lower than the 19.8% in tight control, but they didn't emphasize that for preterm birth, the 35.6% in less tight control may have been higher than the 31.5% in tight. And I just want to note that the economic, in the economic analysis, the costs moved in the same direction as the clinical outcomes. So not only were clinical outcomes worse in less tight control, but the costs were also higher, and on average about 6,000 Canadian dollars higher per woman, driven by neonatal care costs. Now, we must be concerned about developmental programming, and so in the CHIPS child follow-up study, we looked at change in Z-score for weight by year compared with the year before, and our primary outcome was measured at 12 months of age at a study visit. And basically, there was no compelling evidence for developmental programming of growth. So if we looked at change in Z-score for weight, the hypothesis being that if there had been some restriction of growth in utero, that after birth, when that restriction was released, there could have been accelerated postnatal growth. But you will see here in the red box that the box and whiskers plot in black reflects less tight control, and it looks the same as the box and whiskers plot in red representing tight control. So no evidence of developmental growth. Now, the CHAP trial has been recently published, and its results are entirely consistent with CHIPS, thank goodness, and I'd like to just take you through those results. So CHAP recruited from 2015 to 2021 and was published last year, and this was the treatment of mild chronic hypertension during pregnancy. So CHAP recruited entirely women with chronic hypertension versus the 75% recruited in CHIPS. Blood pressure was 140/90 or above on 2 occasions, or a prior documented history of chronic hypertension. The results are presented in the opposite way. So antihypertensive therapy, the antihypertensive therapy arm was treated to a target under 140/90, and this is similar to the CHIPS tight control arm. And the blood pressure achieved in this arm was 130/79 in CHAP, and then the other arm was similar to less tight control. So this was the no to low dose antihypertensive arm, and treatment for a blood pressure of greater than or equal to 160/105 to treat and just get blood pressure just under that. But the blood pressure achieved was 133/82. Both trials prioritized labetalol as first-line therapy. In CHAP, about 40% of women were recruited very early in pregnancy at under 14 weeks, and about 45% were on aspirin at randomization, up to just over 75% by birth. The primary outcome was a composite of maternal and adverse fetal newborn outcomes. Preeclampsia with severe features, so that's the very low platelets, eclampsia, etc. Medically indicated delivery at under 35 weeks, placental abruption, or perinatal death. And the safety outcome was small for gestational age infants. And then the secondary outcome was similar to CHIPS in being a composite of serious maternal morbidity. It was a big trial. 2,419 women were randomized, and 2,408 completed the trial, with 1,208 in the active treatment arm and 1,200 in the standard treatment arm. So the active treatment arm is equivalent to tight control, seen here in the CHAP analysis table, compared with standard treatment similar to less tight control. And you can see here that the primary outcome was significantly less common in tight control. This was the composite that I mentioned, and this was true whether you looked at a complete case analysis or whether you looked at the imputed analysis. And of note, preeclampsia with severe features, as well as indicated preterm birth at under 35 weeks, were also significantly less common in the active treatment group. And while abruption and fetal or neonatal death did not differ between the groups, the direction of effect was the same. And obviously they're far less common, so you wouldn't have expected a significant difference on their own. Now, the safety outcome was about fetal growth. And remember, I said that a large proportion of the patients were treated from very early in pregnancy. And so they looked at two different kinds of growth charts and the complete case and imputation analysis. And no matter how this was looked at, there was no significant difference in small for gestational age infants measured as under the 10th centile or under the 5th. And the number of patients who would need to be treated with antihypertensive therapy to normalize their blood pressure to prevent one primary outcome was low. It was 15. Now, CHAP and the other maternal outcomes were also consistent with CHIPS. So the composite cardiovascular complications, the serious maternal complications, was no different between the groups, although the direction of effect favored the active treatment as it did with tight control. Severe hypertension was significantly less common in the active treatment arm. And here was the surprise, is that any preeclampsia was also significantly less common in the active treatment arm. So an extra bonus. And there were no important subgroups for which the treatment effect was different. So CHIPS and CHAP have complementary strengths. And I've highlighted the ones that I think are most important here in yellow. So CHAP was much bigger, 2.5 times the size of CHIPS, but CHIPS was international, being undertaken in 16 countries. CHIPS enrolled both women with chronic hypertension and those with gestational hypertension, but CHAP had a more ethnically diverse population enrolled. As well, the majority of the patients were of BMI of 30 or more, whereas that was about half of the women in CHIPS. And CHAP also recruited women with pre-gestational diabetes, so an important subgroup that had actually been excluded from CHIPS. And then finally, although the trials reported mainly on women treated with labetalol or nifedipine, CHIPS also had a very healthy proportion, so at least 40% of women who received methyldopa as one of their antihypertensives, and so that has relevance to global health. So if we agree that we should be treating with antihypertensive therapy in pregnancy, what should we use? Should we be using the labetalol and the nifedipine and methyldopa that were used in these trials? So we undertook a network meta-analysis published last year. So 72 trials were included, 61 with just almost 7,000 women were informative. And I've shown here the network plot for the severe hypertension outcome. And so the size of the circles represent the number of arms that use that drug, and you can see placebo no therapy was the most common one, and the thickness of the lines that connect the comparisons show you the number of women enrolled in such a comparative trial. So you can see here that methyldopa and beta blockers have been most commonly compared for severe hypertension. So let me take you through the key outcomes. So this is a league table for the outcome of severe hypertension, which occurred at a median of 13%. And so I want you to focus on the columns, the treatment columns, and you can see here that the most commonly studied antihypertensives are better than placebo no therapy. So you can see all of these odds ratios have point estimates that are well below 1 with 95% confidence intervals that don't cross. And actually, labetalol may be better than methyldopa. You can see the upper 95% confidence interval is close to 1, but doesn't cross it. Same setup if we look for proteinuria or preeclampsia, median of 14%. And we can see here there were no differences other than labetalol comparisons with placebo no therapy, methyldopa, or calcium channel blockers. And in those comparisons, labetalol came out as significantly decreasing proteinuria or preeclampsia, although you can see here that the upper 95% confidence interval is 1. Now, perinatal death, labetalol was actually associated with a reduction in perinatal death. Now, there were no differences in birth weight under the 10th centile. However, I want you to notice that in this league table, labetalol and beta blockers are over on the right side of the table with point estimates that are above 1 But in preterm birth, they're sitting on the left side of the table with point estimates below 1. This is really reminiscent of the CHIPS trial results, in which we look to see how birth weight under the 10th centile and preterm birth compared with each other. So if we look at the gestational age at randomization, and you look at the x-axis for each of these graphs is the gestational age week, and the y-axis is the odds ratio. And so anything that's completely below the line is an odds ratio under 1, and completely above the line, an odds ratio greater than 1. And you can see here for birth weight under the 10th centile that if you are randomized to less tight versus tight control, up until the point of about 28 weeks, birth weight under the 10th centile is less common. However, for the same gestational age period, less tight control is associated with an increase in preterm birth. So you see that there is actually no difference in the primary outcome, which represented death or illness. And this is reflected here in the network meta-analysis table for neonatal care unit admission. And you see labetalol and beta blockers are in the middle, and none of these comparisons. So in conclusion, the network meta-analysis showed that all commonly prescribed antihypertensives are more effective than placebo or no therapy in reducing the risk of severe hypertension. Labetalol may also decrease proteinuria or preeclampsia and perinatal death, but we made many comparisons that risk finding significant results by chance alone. And for many safety outcomes, the evidence is lacking, particularly things like perinatal death, that are very uncommon. There are ongoing trials of specific comparisons, such as the Giant Panda trial of oral nifedipine versus oral labetalol for all severity of antihypertensives. The ISSHP, the International Society for the Study of Hypertension in Pregnancy, at the moment makes the following recommendations: that initial therapy should be with monotherapy from the first-line drugs mentioned here based on small RCT, so labetalol, methyldopa, nifedipine, other beta blockers, as shown in the network meta-analysis. The choice of agent should be based on characteristics of the patient, contraindications to a particular drug, like severe asthma, you're not going to use beta blockers or labetalol, and physician and patient preference. It's really important to use a drug that you and your colleagues are comfortable with and that is available. Additional antihypertensive drugs should be used if target blood pressures are not achieved with standard dose monotherapy. And add-on drugs should be from a different drug class chosen from first-line or second-line drugs. And there are some tools that have been published that I'd just like to draw your attention to. You're not supposed to read the details of this slide at the moment. This is in the open access ISSHP guidelines published last year in pregnancy hypertension. And it just illustrates that of the labetalol, nifedipine, or methyldopa that you would start with, if medium dosage of the medication is not sufficient to achieve target blood pressure, then we recommend that you loop back and you add a low dose of a drug of a different mechanism rather than moving to a high dose of monotherapy. This is how we manage hypertension outside pregnancy. And then finally, this is a tool published in our New England Journal review last year that tries to integrate the treatment of severe and non-severe hypertension using the most common medications, and just to try to bring it all into one place, the doses and how frequently they should be repeated. Finally, I would like to thank you very much for your attention today. I've put my email address up on the slide. I'm happy to receive any questions from you, because I would have been delighted to have joined you in person today. So I wish you a good day and a fantastic conference. Thank you.